These are the findings of an inquest into the death of patient X. Patient X's death was reported to the coroner as it appeared unexpected. The role of a coroner is to independently investigate reportable deaths to establish, if possible, identity, medical cause of death, and surrounding circumstances. Surrounding circumstances are limited to events which are sufficiently proximate and causally related to the death. The purpose of a coronial investigation is to establish the facts, not to cast blame or determine criminal or civil liability. Under the Act, coroners have the important function of helping to prevent deaths and promote public health and safety through the making of comments or recommendations, in appropriate cases, about any matters connected to the death under investigation. The coroner's investigator, Constable Brown, has prepared a coronial brief that includes a statement from the treating general practitioner, a family member, and the forensic pathologist. After considering all of the material obtained during the coronial investigation and the evidence given by Dr. Smith, I find that the identity of the deceased, Mr. X, is not in issue and requires no further investigation. In terms of the medical cause of death, I note that a toxicological analysis of post-mortem blood detected the presence of a high level of tramadol as well as morphine and benzodiazepines. I note that the forensic pathologist concluded that this combination of drugs is likely to have led to respiratory depression and death. I accept the pathologist's opinion that the medical cause of death was multi-drug toxicity. Having examined the circumstances in which the death occurred, I note that whilst no formal mental health assessment was conducted by Dr. Smith in the weeks prior to his death, Mrs. X believed her husband appeared to be in a good frame of mind prior to his death, and I accept Dr. Smith's evidence that he had turned his mind to Mr. X's mental state and did not believe that at the time he last saw him it warranted a referral or counselling. Whilst I am satisfied that Mr. X's death was the unintentional consequence of his intentional use of prescription medication, I have some concerns in relation to Dr. Smith's prescribing of Schedule 4 and Schedule 8 medications, and about the fact he did not consider a referral to a pain specialist. Whilst I note the evidence Dr. Smith gave regarding discussions he had with Mr. X about the fact he was exhibiting signs of drug dependency and about trying to reduce his use of medications and to consider a referral to a pain specialist, his contemporaneous medical records are brief, and there is no confirmation in the records of these matters having been considered or discussed. Further, I note that whilst Dr. Smith gave evidence to the effect he was aware of his obligations and responsibilities when prescribing Schedule 4 and 8 medications, with reference to the state and college guidelines regarding the prescriptions of drugs of dependence in general practice, he did not follow these guidelines. Accordingly, I find that Dr. Smith's provision of scripts has been causative in Mr. X's overdose. Whilst I accept Dr. Smith's evidence that he has reflected on his management of patients with chronic pain and his prescribing practices in relation to narcotics, and has undergone further education in this regard, I intend, considering Dr. Smith's responsibilities as a health practitioner, distributing a copy of this finding to the Australian Health Practitioner Regulation Agency to consider whether his practices raise sufficient concern to justify further regulatory investigation within its sphere. I also direct that a copy of this finding be provided to the State Department of Health, Medicines and Poisons Unit, and to the next of kin. I close this inquest.